much for joining us today. We're going to get started really shortly, but we're going to give people a little bit more time to come in. So we'll be back in just a moment. Good afternoon, everyone. My name is Kathleen. I'm an occupational therapist and certified hand therapist, as well as the assistant clinical director of the Chambers Street location. I'd like to welcome back those of you who have attended one of our webinars, and then welcome those who are joining us for the first time. We appreciate you taking time out of your busy days to learn with us. So for those who do not know who we are, Spear is a private outpatient practice that has been around for over 20 years with currently 21 locations all over the New York City area. So we have successfully continued to offer in-person care throughout the COVID-19 pandemic, as well as launching Spear Live for those who are looking to stay at their home and receive care using our telehealth platform. In our clinics, we are strategically going above and beyond the CDC guidelines to ensure the safety and well-being of everyone. You can find more detailed information for those safety measures by visiting our website at spearcenter.com. But we're here for you in whichever way makes you feel more comfortable. If you're looking for individualized care, either in the clinic or through telehealth, please reach out to us at your convenience and we'll get you set up for an appointment right away. We're excited to be with you today to discuss general information of what post-acute COVID-19 syndrome is and who is likely to develop this syndrome. Our presenters will be providing information about what next steps to take if you're experiencing post-acute COVID-19 syndrome and how to get back to what you love to do since life can't wait. As you see, some of us are coming from our homes, and although we don't anticipate any technical issues, please be patient with us if anything goes wrong. As you all know, technology has a mind of its own. So just going through some housekeeping, throughout the webinar, we want to hear from you. So if you have any questions, please feel free to let us know your thoughts in the Q&A feature. To find where that is, please take a moment, hover your mouse at the bottom of your screen, and you'll see Q&A, the option pop up. That's where we want you to put the questions. We'll do our best to address as many of them as we can during the webinar. It's best to put those questions in the Q&A. If you put the questions in the chat feature, we may not be able to get to them during the webinar. So for those of you watching through YouTube, we're monitoring those questions too in the comment section. So please feel free to type those questions in. And then lastly, there's going to be times where there's multiple panelists on the screen. So for the best viewing experience, please select gallery view at the top right corner of your Zoom, and then you'll be able to see multiple panelists at once. So now we're going to talk a little bit about our goals for the day. So what we want to do, we're going to, step one, define post-acute COVID-19 syndrome, which is kind of a tongue twister in and of itself. We're going to introduce Mount Sinai's program. Then we're going to hear from Spear, and they're going to introduce Spear's program. And then lastly, we want to provide resources and recommendations for you guys. So before we get started, I want to introduce our team of amazing panelists. So we're going to welcome everyone onto the screen now. And I will start introducing. So our presenters today, we have Tina Wang, Aimee Bitzel, and Jenna Tosto-Mancuso. Tina is a physical therapist at our Tribeca Chambers Street location.
Hello, everyone.
Aimee is a physical therapist at our Union Square office.
Hi, everyone.
And Jenna is a physical therapist and clinical director of the Precision Recovery Program at Mount Sinai.
Hi, everyone. Thanks for having me.
And then lastly, we have Ben Krause, who's also a physical therapist and an assistant clinical director for our Union Square office. He's going to be helping us with answering your questions in the Q&A today.
Awesome. Hi, everyone.
All right. So let's get started. Ben and I, as well as the other panelists, are going to say goodbye for now. And Aimee's going to take it away with telling us more about what post-acute COVID-19 syndrome is. Take it away.
Perfect. All right. Thank you so much, Kathleen, for the intro. That was wonderful. Hi, everyone. My name is Aimee, as Kathleen introduced me. And I'm going to be providing some background on what post-acute COVID-19 syndrome is, or for short, PACS. And I'm going to talk a little bit about the demographics, signs and symptoms, and what you should be aware of if you believe you or someone you know is experiencing PACS. So what is it? The National Institute of Health and Care Excellence defined it as signs and symptoms developed during or following a disease consistent with COVID-19 and which continues for more than 4 weeks, but they are not explained by alternative diagnoses. The definition, as you can see, doesn't state that a previous diagnosis of COVID is necessary. This is because people during the pandemic went unreported due to medical necessity and uncertainty at that time. Also, these signs and symptoms listed below, I know it's a little bit small, but take a close look at it if you can, mentioned that are not, sorry about that. Also, these signs and symptoms mentioned are not set in stone, but are a spectrum and don't impact everyone the same way. These signs and symptoms can include neurocognitive symptoms such as brain fog, dizziness, loss of attention, and confusion. Autonomic symptoms such as chest pain, elevated heart rate, palpitations. Gastrointestinal such as diarrhea, abdominal pain, vomiting. Respiratory symptoms such as fatigue, difficulty breathing, sore throat, and cough. Musculoskeletal, muscle and joint pain, and some psychosocial factors such as PTSD, anxiety, depression, and insomnia. As you can see, PACS can present in many different shapes and forms and can impact each person so differently. As such, it's important to recognize additional signs and symptoms of long COVID to best guide you and additional medical professionals on accurately diagnosing you early and getting you the care that you need. So now that we've kind of dove into those things, let's go into patient demographics. All right. So currently, the research on who is more likely to experience PACS is pretty limited just because of the state of the world and how early it's been. And unfortunately, a lot of this has been restricted to sample sizes, including hospitalizations or specific groups of people just based off of resources alone. So based on the research provided and our own experience in treating patients with PACS, the most reported individuals have included females more so than males, and at an average age range between 20 to 40 years of age. This may be due to these individuals typically reporting symptoms in greater amounts to medical professionals or are able to use apps and other technical reporting methods compared to older or younger counterparts. Also, because this population is of a very active age, increased limitations in daily activities or exercise can be more noticeable and incentivizes these individuals to want to seek care and return to their previous lifestyles. Lastly, these individuals tend to initially present with mild to moderate symptoms and were not previously hospitalized. Despite these demographics, PACS and these characteristics are not mutually exclusive, and any signs and symptoms of PACS should be considered despite these common factors. Thanks for listening to my speech, and now we'll hear from Jenna regarding Mount Sinai's program.
Perfect. We can go on to the next slide. Perfect. Thanks so much for the warm introduction, Aimee. So building off of what Aimee just discussed, the idea of post-acute COVID syndrome or long COVID really spawned out of the initial COVID pandemic. And so at Mount Sinai, during the acute pandemic or the beginning of the pandemic, we quickly realized that there was a subcohort of patients who, after their acute initial infection, particularly those who had mild to moderate initial infections, just were not getting better. And so we started noticing the development of a sequela that was really consistent with the above. Oh, I just saw that we can't see me. Let's see. Hopefully that is working for all of you now. Perfect. And so as I was saying, so we realized there was this ongoing presentation for patients, about 20 to 30% who just were not getting better. And the development of the post-acute COVID sequela really started to develop. So under the guidance of a really incredible interdisciplinary team here at Mount Sinai, we quickly pivoted to start to assess ways that we could make a difference. And so here in the Department of Rehabilitation and Human Performance, in conjunction with our colleagues in the Department of Cardiology, as well as a number of different interdisciplinary providers, we developed the Post-Acute COVID-19 Syndrome Rehabilitation Program. And so Mount Sinai's multi-centered, patient-centered care program largely included individuals from complementary care, individuals from that multidisciplinary team, and really how we connected with SPEAR is through our trusted rehabilitation network. So Mount Sinai works with a number of different private practice outpatient clinics throughout the tri-state area. We've also expanded to have both national and international partners to really begin to spread the knowledge that we've gained from working with patients with long COVID, and more importantly, sharing the rehabilitation program that we developed. So next slide. Perfect. So in response to the development of long COVID, our team here at Mount Sinai developed what we call ACT for PACS. And so there are a lot of acronyms flying around. ACT stands for Autonomic Conditioning Therapy for Post-Acute COVID Syndrome. And so I do like to clarify why autonomic conditioning therapy. So as Aimee had touched on in her introduction, many of the symptoms that we're seeing in long COVID are synonymous and likely related to the autonomic nervous system. So when we think about the autonomic nervous system, we think about sympathetic and parasympathetic control. And when there is a disconnect in that system, we often see manifestations of the symptoms that Aimee described. Things like fatigue, significantly out of proportion to exertion, exercise or activity intolerance. That might even include things like activities of daily living, not necessarily pure exercise. Things like chest pain, unexplained cough, unexplained thermoregulatory changes. And so when we look at that myriad of symptoms, we don't understand the pure pathophysiology of it yet. Admittedly, long COVID, post-acute COVID-19 syndrome, this is a new diagnosis that we in the medical community are learning more about every day. So what we did with our development of the ACT protocol has been to look at like diagnoses, look at the literature and the primary interventions for similar presentations. And really what we found is that it needed to be titrated. It needed to really address the intensity of the symptoms our individuals are facing and meet them where they are as far as symptom titrated activity begins. So the ACT for PACS protocol is a 3-phased program. Individuals begin with supine-based activity that is titrated by their symptoms, slowly progressing to the upright position, and then getting into the concept of graded aerobic activity. And so your therapist who you would be working with, our ACT for PACS program through the Mount Sinai program, will walk through those different types of interventions, really aimed at first gaining symptom stabilization, and then from there progressing to more intensive exercise or activity, should I say, to really get back to those things that our patients enjoy and love doing. Next slide, please. And so I'm really quite excited. This is actually one of the first talks I've gotten to do where I'm able to talk about this. And so our group has an article or a recent publication in preprint, which is really exciting. It's under peer review right now. And so I definitely owe kudos and compliments to every single person on that publication under the leadership of Dr. David Petrino, has been absolutely incredible in getting us to this point. And it's a really nice opportunity to report on the positive outcomes of the Act for PACS program. And so really what we're seeing is the symptom titrated, very meticulously prescribed return to activity and exercise does have the capacity to improve fatigue for patients who are experiencing long COVID, as well as individual perception of change. So noticing and recognizing a change in their symptom, particularly that of fatigue, which, as we discussed, is indeed the primary symptom for post-acute COVID-19 syndrome. And so while this is very preliminary research on the Act for PACS protocol, we are very, very excited about it and do hope that more exciting, really helpful research can come out of it. So with that, I will turn it over to Tina, who can take us through.
Awesome. Thanks, Jenna, for sharing the Mount Sinai ACTS program and all the research. Hello, everyone. My name is Tina. We're going to be talking a little bit more about Spear's involvement and collaboration in treating individuals with PACS. So what's amazing about this partnership is that Spear does work really closely with Mount Sinai to treat individuals with PACS. Physical therapy doesn't work in silo by itself, but rather there's a collaboration among the medical team to provide the most appropriate care for the patients. So here at Spear Physical and Occupational Therapy, our therapist focus is providing individualized patient-centered care, and that's going to look a little different for everyone that comes in. It's very important before you come in for physical therapy that you're cleared by your physician or a cardiologist to participate in any physical activity. We then work closely with every individual to tease out their symptoms and primary complaints, since we know that everyone that comes in will probably have a different subset of symptoms and goals. So we currently have 21 locations throughout the city, and each site has an appointed therapist that has undergone training to provide the most appropriate treatment. We will be providing that resource via email following the webinar, so look out for that. So then when you come in for your individual sessions, you can expect the focus to be on three major things. First and foremost is patient education, how to best manage your symptoms throughout the day between sessions. Then we'll have a manageable home exercise program for you to do. And then within session, we'll be doing symptom titrated exercises. So now that you know a little bit more about what PACS is and the Mount Sinai and Spear collaboration, the question now becomes, what's the next step for you, for everyone seeing this? First and foremost, if you are experiencing any of these listed symptoms or think you may have PACS, please reach out to your primary care physician to discuss next steps. Really gauge your signs and symptoms to communicate with medical professionals so that they can more effectively recommend the necessary services you may need. The next thing to consider is when participating in any physical exercise, it's important to have a gradual exposure based on your symptoms to physical activity. So this is going to look very different than what you've been used to, and it's not going to look like a 3 sets of 10 repetition. Your body may respond not immediately after you exercise, but the days following. So it is important to slowly progress into any physical activity. It is best to do so under the supervised care of a physical therapist or a medical team. And the last thing to consider is ways to better manage your energy throughout the day. So on the flip side of wanting to incorporate physical activity, it is just as important and sometimes even more important to focus on energy conservation. So things to think about is working on paced breathing throughout the day, taking nice deep diaphragmatic breaths, and taking rest breaks as needed throughout the day. As a tip, it may be beneficial to keep a journal of what your symptoms are that day and how it changes based on your activity. It's a great way to track what are some of your triggers and how best to work around them. So that's the end of the presentation. Now we're going to be transitioning from the presentation portion to the Q&A portion. I'm going to invite back Kathleen, Amy, and Jenna for that.
All right, amazing. Thank you so much, guys. So Ben has been sorting through your questions, and we're going to try to answer as many as we can. So starting with this question, what are the most common symptoms that people are coming into physical therapy for? So I'll open that up to the floor, whoever wants to take that one.
Yeah, I can kind of dive into that. So I'd say out of the group of individuals that I'm currently treating, the main one is the autonomic nervous system, and a lot of just the chronic fatigue, especially with that activity that Tina said that comes not necessarily immediately during an activity, but more so after or into the next day. A few others that I'm typically seeing is more of the neurocognitive. So a little bit of the brain fog, a little bit of memory loss, some sensitivity to either computer screens or sunlight. And then I would say others, definitely a little bit more of the shortness of breath or chest discomfort too. How about you, Tina or Jenna? What do you think?
I can talk about that a little bit. Similarly, across the board, I've been seeing predominantly individuals with more like general fatigue and just like with day-to-day activities being really tiring and exhausting to do, and just chest pain in general. Sometimes I'm noticing people also developing some like tingles and numbness sensation throughout their body or swelling. So really a wide range of symptoms across the board with these people.
So, I can concur with that. I think it's really important to distinguish fatigue that our patients are experiencing with long COVID versus, I know oftentimes the term chronic fatigue comes up, or ME, CFS. And it's really, I think, a very important thing to distinguish that presentation might look different in each of our patients. Like we had discussed, that underlying pathophysiology likely being related to the autonomic nervous system largely lends itself to presentations of just a myriad of symptoms. And so absolutely our group is seeing chronic fatigue out of proportion to exertion, chest pain, malaise, neurocognitive brain fog, absolutely. We have also seen presentations for things like dizziness that are really unexplained. It can be vestibulogenic, but not necessarily all the time. So definitely that myriad of symptoms.
Yeah, I think honestly, Jenna, you just segued perfectly into our next question, because our next question is general weakness the same as chronic fatigue? So I'm going to let you guys.
I don't mind piggybacking off of that last comment. So no, general weakness and chronic fatigue are not one and the same. Chronic fatigue is a formal diagnosis or definition for a separate syndrome that mimics and mirrors things that we're seeing in long COVID. And I am a pretty staunch advocate for not using the term chronic fatigue until we have a better understanding of why this is happening. When we see general weakness, and we can see it intermittently with long COVID, I will say that it doesn't pop up quite as frequently. We often see general weakness secondary to decreased activity tolerance or inability to move like you previously were before your COVID infection. But those two are not synonymous, no.
Great. Thank you so much. All right, going on to our next question. So this is a question coming from a fellow occupational therapist, Hey. What would you say is the most important starting point for treatment?
I can start with that. I think one of the first things I always like to start with is understanding what the patient's symptoms are and like what kind of brings that on for them, whether it's what sort of activities, and then kind of work into some of the better understanding of like how we can slowly progress into activity, recognizing when symptoms come on and how to back right out of that.
Great. Thank you so much. Okay, this is another thing that kind of relates to occupational therapy. I'm loving this little psychosocial stuff. So what do you guys think? Is there any role for group therapy or CBT with these post-acute?
I don't mind jumping in on that one. So I can say yes. I think it was touched, and I apologize, Aimee or Tina, who had mentioned it, or all of us at that point, but the neurocognitive effect is one end of it, but also psychosocial variables and things like development of anxiety and depression in relationship to really the limitations of long COVID absolutely is warranted. Our group out of Mount Sinai and thereby through SPHERE makes frequent referrals to neuropsychology and psychology, many of whom do create or provide interventions surrounding CBT. Additionally, we are working toward the development of a group therapy session. Absolutely, it's something that can be considered. I know if we don't have those direct resources immediately available, there are quite a number of support groups throughout. I know social media has become a really huge starting block for a lot of patients with long COVID. So we definitely advocate for that. But in more directness to answer the question, yes, I do think there is a place for CBT and group therapy. Absolutely.
I love that. Amazing. So the next question is, how is the autonomic nervous system deficiency treated? Is it only through these exercises, or is there a medical treatment?
I don't mind jumping in on that if you want to, or Aimee, if you want to jump in.
I guess I can jump in on the exercise if you want to jump in on more of the medical component, just because
Sure.
for Mount Sinai, I'm sure you know. So yes, through a lot of these exercises, it is titrated to slowly build up your ability to, or of your autonomic nervous system to adjust to on and off exercise. So a lot of the program incorporates periods of rest break to activity in those exercises. So it's basically turning on your nervous system to then adjust to those exercises, and then giving ample amount of break so that your nervous system can then calm down to that baseline component. And so basically you ramp it up to then calm it back down, so that eventually, as we continue through the protocol and ramp up intensity, that's how it's going to eventually build, so your body can recognize how to change more quickly and adjust to different activities that you do.
Absolutely. And to tag off of that, there is currently no medical intervention. There is medical management. And so many of our patients will meet with their physicians upon entry into the program, who will medically evaluate. We do say the $1 million workup can come, and it's not surprising when medically there is no biomarker, meaning that your tests will come back and look okay. And that includes traditional tests for autonomics, such as a tilt table test. But medical management definitely is, in addition to symptom titrated activity, managing any other secondary outcomes that might come up.
That is great. You guys truly are experts on this. All right, the next question is, what is the difference between symptom titrated exercise and graded aerobic exercise?
I can take that if that is helpful. So this is something that actually has become rather controversial, admittedly within the past month or two. And so a lot of the conversation surrounding the difference between graded aerobic exercise and symptom titrated exercise is really born in this need to distinguish long COVID and the symptom presentation and underlying pathophysiology or rationale for long COVID side by side or paralleling like diagnoses, things like CF and ME and chronic fatigue. And so when we look at the literature, the clinical indications for something like graded aerobic exercise in its purest sense, we really see that it is not well tolerated, and it's very, very provocative. If we look at the literature surrounding something like graded aerobic exercise, even in the face of diagnoses like dysautonomia or POTS, which is also another term or diagnosis that comes up, it's poorly tolerated, even though it is considered the gold standard. And like Aimee had just described, this idea of turning on that parasympathetic versus sympathetic nervous system. And so when we think about the interventions for long COVID, we're really quite keen to differentiate that what we are doing in autonomic conditioning therapy, or the ACT program here between Mount Sinai and Spear, is not so much pure graded aerobic exercise where patient might anticipate that they will be on a treadmill and they will be pushing their heart rate boundaries to significant levels, which in full agreement will absolutely flare symptoms up. But rather it's the slow progression of supine-based exercise that doesn't tax the autonomic nervous system quite as much, slowly progresses to building up that tolerance for symptom stability, and thereby after can start to really increase things in response to patients' symptoms. So Aimee, I believe it was you or Tina explained, there's no 3 sets of 10 that doesn't go, it goes out the window completely. And we really work on how you're responding to activity to really understand how to progress your program from there.
That's awesome. Thank you. So kind of going off of the program, how long does the protocol typically take?
Jump in and talk a little bit about that. There's no one timeline for how long you will be doing like PT or the protocol. So the protocol is set out to have a 6-month duration. That doesn't mean you'll be in physical therapy for 6 months, but it really depends on how you respond, how your symptoms respond to any load and any activity. And that's how we base your progression and how well you're doing and how we move you through the autonomic conditioning therapy that Mount Sinai program has.
Yeah, and to go off of that a little bit too, I mean, I've had an assortment of patients who have gone through the program very quickly and are more on independent mode now, versus other patients where it's taken certain weeks have been harder than other weeks. So it kind of rolls into everyone's symptoms are so different. And that progression is going to be fantastic once you slowly start to build and you notice those smaller changes to everyday life. So I know it's more of a marathon than a sprint, but that's why we're here to help guide you through it.
Yeah, and this next question kind of piggybacks off of that. So I know you guys said it's hard to say how long it's going to last, but has there been any research or is there any evidence on the length of how long COVID symptoms can last? Because it seems like a roller coaster. Some days are good. Some days it's hard to even just get out of bed. Some days exercise can happen. So any research so far?
I can take that one. Unfortunately, there is no concrete research right now that gives us a timeline. And as we just discussed, every symptom is different. The autonomic nervous system responds in a different sense, patient by patient. I tell all of my patients and all of the therapists I work with that this is not a linear thing, right? This is more of a sinusoidal wave. It's going to peak and valley, and ideally that will slowly start to become more of a flat line as those symptoms start to improve. Right now, in our most recent data assessment, we did note that the average length of time for patients in therapy was several months. And as Aimee had highlighted, that can vary depending on where patients are starting. Admittedly, also, it's not uncommon for some weeks to be a little bit harder and for patients to move more slowly through those weeks. But we do encourage, don't be discouraged by that. This is the nature of what we're dealing with, where sometimes we'll be going smoothly and we can see flare-ups. But unfortunately, research is in the work per usual, and hopefully in the future we'll have more to report on that.
And I know in like the perfect world, months of physical or occupational therapy are great, but what are your pieces of advice for those who were doing therapy and then insurance stopped covering only a few weeks in? Are there things that can be done on their own, or any kind of take-home exercise that you would be okay with the patient doing independently?
I can follow up on that, and maybe we can go in a group and see if anyone else has any other takes. Clinically, we are really hesitant about providing the ACT protocol or program without supervision of a therapist. And this is largely because symptom titration is really an art form, if you will. And it really is helpful to have your skilled therapist who can evaluate from both the physiological level, but also from that symptom level. In the event, and we have unfortunately seen this happen, and as all of us on the call are clinicians, it's a really wonderful time that we'd love to join the efforts to advocate for our patients with long COVID, especially when it comes to insurance. But it is helpful to have the therapist creating home exercise programs that are guided. I have myself sent out some very lengthy home exercise programs that I felt would give some concrete direction. But it's definitely something that as a medical community, we want to advocate for.
Yeah, and I'll piggyback off a little bit. I think Jenna explained it perfectly in regards to if you know that you've had physical therapy already this calendar year and some of your sessions have been shortened as such, I would say keep that communication open with your therapist, because then they can hopefully have a good game plan set in terms of maybe spacing out your appointments enough to then have you implement certain times to then change the protocol as you move along. I think also open communication is key. So I know for myself, I really do instruct my patients like, hey, after our day of like trying the new week's level, email me, give me an update on how you're feeling. I don't want you to push through anything if your symptoms are going above this amount that we kind of dictated together personally for them. So I think that line of communication is key, and set kind of that standard of communication so that you can best move forward and receive the care that you need.
And to back off of that, Amy, like I completely agree, open communication across the board. Something I mentioned earlier was like journal your symptoms, journal what's happening, just based on your activity for the day, how you're feeling, because that's a really good way to like self-monitor what you're feeling. And then it's a great bridge between if you aren't able to come due to insurance reasons on a weekly basis for PT.
Thanks, guys. That's really helpful. I agree. As a clinician, all we can ask is for communication. So I would, again, encourage you to reach back out to your therapist for sure. Just a few more questions. So what is the difference between PASC and PACS? Jenna, I think you're taking that one.
I can take that one. Yeah, absolutely. And again, this has really come into conversation. So our group works quite closely with NIH and CDC, and the term PASC has come out pretty recently. And PASC stands for Post-Acute Sequela of COVID. And so what the PASC acronym or PASC diagnosis typically, or NOMER, names is the entire spectrum of potential symptoms presenting after a COVID infection. And this includes individuals who had a more severe COVID infection, who were potentially hospitalized, potentially ventilated, potentially with more long-standing respiratory presentations. And so we often refer to this in non-COVID settings as PICS, post-intensive care syndrome. A lot of acronyms, lots of T's going around, but we really like to highlight that that PASC term really encompasses the entire spectrum of any type of presentation after COVID, where PACS is quite specific to what is often called long COVID, and really that's capturing the post-acute COVID syndrome. So that is the difference in the terms.
They're so close. And on
one letter off.
It's almost hard to say the difference, but all right. And then lastly, what are some other research studies that are available for patients with PACS?
Sure. I'm happy to chime on that. So both here at Mount Sinai, and there's definitely other institutions, we're really quite excited about the work that we're leading here. In addition to our clinical programs, there are several research studies going on for patients who might be interested, largely surrounding identification of potential biomarkers for long COVID. So that includes looking at things like vascular biomarkers, blood-based biomarkers, things of that nature. I'm happy to share our contact info if anyone is interested, so they can reach out to our team to see if they might be appropriate for a research study. But really, as a medical community, we're all just trying to get a better understanding of what really we are up against with long COVID, to really better inform how we can help patients. And so while the clinical efforts are absolutely riveting, and really it's just an incredible demonstration of collaboration, it's always an exciting thing to see new research taking place.
Yeah, it is amazing because it's only been a little over a year and you guys have already done so much. So that's like very much a fast track to research. But
absolutely.
We do have one more question that just came in. So having done some research, it seems that long haul COVID accelerates the autoimmune system and keeps it on mode perpetually, which might lead to the fatigue conditions. They're asking, is there truth in this? Is this what you guys mean by it affects the autonomic nervous system?
So I can take a jump at that one, as I just reread it to make sure that we were talking autoimmune. Unfortunately, there is not enough evidence yet out there. And unfortunately, that is the answer I hate giving, particularly as a clinician who works in research, but that is where we are. There is not enough information there. That is a theory currently being researched, both nationally and internationally, trying to better understand the mechanism for changes in the autonomic nervous system response. There is theory that it could potentially be immune mediated and thereby affecting many of the nerves or the autonomic nervous system in and of itself. But unfortunately, not enough research out there quite yet.
Amazing. And then have you guys seen, or how common is the symptom of hair loss with post-acute COVID syndrome?
Yeah, I can touch on that a little bit. Sorry, clear my throat a little bit. So I've actually had a few of my patients reach out to me and say, hey, this has been a common symptom. There hasn't been much of a research behind that or just explaining kind of the reasoning behind that. So I would say just be aware of it. And don't worry, it is a very actually common symptom that I've kind of noticed across the board for some of my patients.
I could comment. We've seen that at about under 10% in our cohort, but now then, yeah, it has been reported.
And I've seen it in a few people as well, but yeah, it could be one of the symptoms, but there's a wide range of symptoms that fall under the bracket of PACS as well. Yeah.
Great. Well, I think that's it for questions. If anybody else has any questions, you can feel free to add them now, but you guys did an awesome job answering those questions. It's amazing to me how much you guys know. So thank you for knowing all that you do. We hope that it was valuable and that you learned more about post-acute COVID-19 syndrome. I know I did. If we didn't get to your questions, though, we will do the best that we can to answer those. So we'll put our information up on the slide right now. You can feel free to reach out directly. So as a reminder, those presenters were Tina Wang, Aimee Bitzel, who are both physical therapists at Spear, and then Jenna Tosto-Mancuso is a physical therapist and clinical director at Mount Sinai. So feel free to jot their information down so you can reach out to them directly with any questions or to schedule an appointment. So you can reach out to them directly for that as well. And then our Q&A moderator was Ben Kraus. Thank you, Ben. He's the assistant clinical director and a physical therapist at our Union Square office. And I am Kathleen O'Donnell Pickard, assistant clinical director at Spear Chambers Street location. So feel free to reach out to us as well. If you have any questions, we'd be happy to facilitate you guys getting to the right therapist. And you can reach out whenever you need. So at Spear, we treat an array of conditions from head to toe, so not just what you've seen today. We are open for in-person visits as well as telehealth sessions still. So if you feel like you could benefit from some individualized guidance and treatment, please don't hesitate to reach out to any one of us. You can reach out individually and we will personally coordinate you being set up with the right team member for you for an evaluation. And lastly, we are gonna be hosting these webinars throughout 2021, covering a variety of topics. So we look forward to seeing you there. Please follow us on social media and check your inboxes to learn more about what's up and coming with these webinars. Thank you so much again for spending time with us today. And we hope you enjoyed the webinar as much as we did. And we wish you all the best. Bye for now.